So we are on live, so we are good to go now, sir.
Hello, doctors. Good afternoon and welcome to this webinar on the role of Oseltamivir in flu management. This webinar is brought to you by Hetero Healthcare, an innovative pharmaceutical company. For Hetero Healthcare, the journey began in 1993. We have 30 plus years of excellence with 36 state-of-art manufacturing facilities, 300 plus products in portfolio and presence in 126 plus countries. Hetero Healthcare has 21,000 employees globally and is one of the largest closely held pharmaceutical company in India. Hetero Healthcare is among the largest manufacturers of ARV, APIs, and FDFs in the world, and is Asia's largest manufacturing facility at ACZ Complex, Visakhapatnam, Andhra Pradesh. Hetero Healthcare is 360-degree solution provider, striving to fulfill unmet healthcare needs, reaching to customers across India with wide product range encompassing multiple specialties. Hetero Healthcare pioneers in quality and innovation and has the distinction of bringing 4 biosimilar products to market within 5 years of initiation. They are darbepoetin alpha, rituximab, bevacizumab, and adalimumab. During COVID-19 pandemic era, Hetero Healthcare, the pioneers in antivirals, offered Oseltamivir, Favipiravir, and Remdesivir to the patients, because of which, in August 2020, Hetero Healthcare received an award of Pharma Excellence for COVID drugs. Today's webinar, role of Oseltamivir in flu management, we have got Dr. Pramod Jog sir as our moderator. Welcome, sir, to this webinar. Dr. Pramod Jog is MD, MNAMS, FIAP and FICMCH, Sir is PG Diploma in Pediatric Infectious Disease, Best Performer at ADVSA France 2011, MA in Sanskrit and Proficiency in French and Spanish. Sir, Sir is Director Home to 18, Professor of Pediatrics at D.Y. Patil Medical College, Pune, National President, Indian Academy of Pediatrics, IIP 2016, Standing Committee Member and International Pediatric Association, IPA, Steering Committee Member, GAV, CSOSC, Standing Committee Member, ASPID, Asian Society of Pediatric Infectious Disease, Consultant Pediatricians, Medipoint, Jupiter, Ankura, New Samgate General Hospitals, Senior Consultant to UNICEF, and a member of Maharashtra State Pediatric COVID and Results Task Force. With this brief introduction, I hand over the session to Dr. Pramod. Over to you, sir.
Thank you. Just give me a moment so that I will.
Yes, sir.
Yes. Are you able to see the slides? Okay. Are you able to see the slides?
Not as yet, sir.
Okay, just 1 minute. I will start sharing. Now, I think now the slides should be seen. Yeah. Okay. Okay. I hope are you able to see now.
Start certain. Yes, sir.
Yeah.
Clearly.
Can you see now?
Very clearly.
I hope they are seen now.
Yes, sir.
Thank you. Thank you. So with that, we will have an important session related to rational approach to viral respiratory infections, with particular reference to the role of oseltamivir in the management of influenza in children. Everybody should be aware that viral infections are extremely common in pediatric practice, and whether it is respiratory system or whether it is GI tract, 90% of the infections which are faced by a pediatrician are viral in origin. Just in the morning in the OPD, there was a small little child around 5-year-old, and she had a doll in the hand. And when I was examining this small little girl who had fever, cold, and cough, she was looking to the doll and saying, it's viral, as if, I am speaking to the, small little girl. And that girl was speaking to the doll. So even the smallest of the smallest, children, they know that, viral infections are very common, and it's a very, very commonly used word. But gone are the days when, I was not much worried when someone used to say that it's viral. Don't worry, because after this 2009 pandemic of influenza and, the 2021, 22, 2020, all those years of COVID-19, influenza followed by this COVID pandemic of, these 3 years, we have had tough time dealing with these, viral respiratory infections. That is because the initial parts were okay, but after 4 or 5 days, there was a second phase where there was immune activation, cytokine storm, and that's why we are worried about viral infections these days. And viral respiratory infections are no exception. Okay, so remember that in pediatric practice, majority chunk of the pediatric practice, no doubt, is of viral infections, and they range from very mild to very severe infections, and they are many times treated irrationally because it's extremely difficult for some of our colleagues to differentiate whether it is viral or bacterial, because offhand we do not order investigations to rule out viral or bacterial infections. And that's why it is extremely important that we know as to how to differentiate viral from bacterial infections. And the most important thing is, when fever comes down after giving paracetamol in a child with viral infections, usually the child starts playing and almost comes back to normal. This is called as normal in the interfebrile period. While in bacterial infections, even when the fever comes down, the child doesn't appear to be, his or her own self. The mother says, sir, every time the fever comes down, usually, he starts behaving normally. He will hit his elder brother or sister. He will throw the toys here and there. But today he is not doing anything. He's not eating. He's not smiling. He's not playing. He's simply lying down. Fever has gone down after paracetamol. So remember that bacterial infections in the interfebrile period, the child doesn't appear to be normal. One important thing is that viral infections usually affect all the systems of the body. So even though the virus is respiratory in nature, the manifestations also include some other systems. So a child with, for example, influenza may have additional vomiting and loose motions indicative of involvement of the GI tract. Measles, for example, when we get a child with measles, he has cough, cold, and fever. Then after 3-4 days, usually the child starts getting rash. During this period, the child might have gastroenteritis, and so on and so forth. Sometimes, because there is mucosal inflammation in the urinary system, the mother will say that the child, while passing urine, is crying. So in a viral infection, more than one system in that child is involved. And within the family, not only the child, but his brother, sister, maybe some of the parents, usually they are unwell. So in a family, there are more than one members who are unwell. And within the community, not only one family, but the neighbor's family or the other family, that's also unwell. So it's like, something like more than one system in a child, more than one member in a family, and more than one family in the community. While bacterial infections are not that generalized. If a child has infection of the tonsils producing follicular tonsillitis, it will produce at the most, the tenderness of the cervical submandibular lymph node. Okay. So that is almost localized. But this child won't have pneumonia. This child won't have in general rash, etc. Okay. Similarly, for example, if there is a bacterium called Shigella, if it produces bacillary dysentery, then it will produce blood and mucus. That won't produce, respiratory symptoms. What I'm trying to tell you is that respiratory infections because of viruses usually have involvement of other parts of the respiratory system also. That means the same child who has tonsillopharyngitis of viral nature will also have some kind of, lower respiratory tract involvement. And bacterial infections, on the other hand, will be usually localized. This is very important because knowledge of this fact will avoid irrational use of antibiotics. And that is why whenever you do not have a clue as to whether it is viral or bacterial, remember 90% of the infections are viral. Again, try to remember whether it is something which is a treatable viral infection like influenza, because the only infection which can be treated effectively with antivirals is influenza, where we can give oseltamivir in the first 48 hours of the onset of the infection. And that is why one should always remember that if a child comes with cold and cough and fever, and if he has high fever with chills at the onset, and he has headache, and he has weakness, and he has muscle pain, it is almost always influenza, particularly in times when there is influenza going on in the atmosphere, and when your colleagues are also reporting lot many cases of influenza. So here the right treatment would be to use oseltamivir empirically and not to use antibiotics like amoxicillin. This is something what is known as the rational use of the antimicrobials which are at our disposal. Okay. So after COVID, what has happened is that the spectrum of pediatric viral respiratory infections and the nature has changed. I remember in 2022, once COVID pandemic was on decline, then the viruses, which were not manifesting themselves till now, they started coming up. So there was hand, foot, mouth disease, then came respiratory syncytial virus, then came adenovirus. Then in areas where measles vaccination was poor, measles outbreak started occurring. So one should remember that whenever parents tell you that this child is getting these infections off and on, please tell them that during the COVID era, children were indoor, adults were indoor. They did not develop the immunity against some of these, viruses, and that is why these infections are now coming up. That's very important. And in a case, for example, a 6-year-old girl who attends daycare, presenting with rhinorrhea along with cough, say for about 8 days, having fever for 2 days, and poor appetite. On examination, when there is clear rhinorrhea present, and remainder of the examination being unremarkable, one must remember that these common respiratory infections are like common cold, and the presentation is with common cold, and the viruses could be any, and later on the progression of the illness could be of a different nature. For example, there is a virus called human rhinovirus, and as you know, rhinovirus means will attack the nose. Almost always, whenever there is plain, simple runny nose, without much of fever, without headache, without chills, and everything mild, 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 then this is, something like a human rhinovirus. However, some of the viruses, for example, respiratory syncytial virus, it will have cold, cough, fever, but then after 2 3 days, the child will start wheezing because of bronchiolitis. And respiratory syncytial virus is one virus where progression to the lower respiratory tract is very well known, particularly in children under the age of 2 years, particularly under the age of 1 year. Okay. Another viruses. Now I told you about influenza and the presentation of influenza. Parainfluenza produces presentation like croup. We will discuss a bit about croup in the course of today's presentation. And these are the children who will have typical inspiratory stridor with barking cough and hoarseness of voice. Okay. Adenovirus. It's a different kind of a respiratory virus. It not only produces respiratory involvement, but it also produces non-respiratory presentations. It will have pharyngoconjunctival fever, it will have mesenteric adenitis, and so on and so forth. And viruses like enteroviruses, like Coxsackie A, they will produce ulcers on the posterior aspect in the oral cavity, which are known as herpangina, which are extremely painful. So all of them have started with common cold, but a bit of difference in the presentation will probably help you to have an educated guess up to what is the name of that virus in particular. Why it is important? So that you know whether the virus could be treated. I told you influenza can be treated. Other viruses, you will know the progression, you will know the prognosis, you will know the duration as to how long this is likely to last. You will know whether antibiotics are needed for this child or no. So, looking at this common cold, which is extremely common viral respiratory infection, a child usually gets on an average about 6 to 8 colds per year, and about 10 to 15% of children can even get about 12 infections per year. And as the child gets older and older, the incidence decreases, and it becomes about 2 to 3 illnesses per year by adulthood. And children who are in the daycare centers in the first year of life, they get more frequent episodes of cold than those who are at home. Okay. And the symptoms and the signs are very simple. The child will have a little bit of a scratchy sore throat along with nasal obstruction and rhinorrhea. And the child will have a cough, particularly two-thirds of the children, they have cough. And the cold may last for about a week or two. And there could be fever along with constitutional symptoms. However, whenever there is change in the color or the consistency of the secretions, for example, the watery rhinorrhea turns very thick, okay, or the color changes to a pale yellow color, then remember that it is not to be taken as bacterial, okay. This does not indicate that the child has developed something like sinusitis or bacterial superinfection. you can always have a look at the inner part of the nose where you may find swollen erythematous nasal turbinates on the inner aspect of the lateral wall of the nose. And the treatment is obviously supportive with antibiotics, and of course, antibacterial therapy is of no benefit. You can maintain the hydration, give warm fluids, maybe at the most you can give some saline instillation. And in general, the cough and the cold products are not to be used for infants and children who are younger than 6 years of age. First generation antihistaminics may reduce rhinorrhea in about 25 to 30%. However, other medications act more like a placebo, and it's not really necessary to use some of them. Remember that this graph will help you explain certain things to the parents. For example, when the viral upper respiratory infection is uncomplicated, initially for the first 1, 2, 3, 4 days, the fever, which will be on the higher side, will slowly come down from day third, day fourth. And the respiratory symptoms will begin after this particular period, indicating that when a child has no fever and when respiratory symptoms begin, one has to tell the parents that this is the normal course of this infection. Otherwise, parents come to you and they say, sir, the fever has gone down, but the child has started, having a cough like hell. So what to do? So you should not get tempted to start antibiotics, because this is the natural course of the viral respiratory infections, which are uncomplicated. However, in case if the child continues to have cold for 7 days or 10 days, then in certain cases we may suspect rhinosinusitis, and we will discuss in the course of this presentation about rhinosinusitis also. So one should be aware of the important clinical red flags which suggest severe disease or complications. For example, as I told you, the child improved for a week and again develops high grade fever. But here the secretions are thick, mucopurulent, and there is, a very bad odor to the secretions. Then it's possible that the child has acute bacterial rhinosinusitis. Again, remember that the presentation could be that the child has this nasal congestion and runny nose and cough for beyond 10 days, and there is no improvement at all. Or there has been temperature right from the beginning for 3 to 4 days and purulent rhinorrhea for 3 to 4 days. Or there could be return of the symptoms after initial resolution. Many times it happens that, child initially feels better, but again, there is increase in rhinorrhea or cough. So either of these presentations could represent acute bacterial sinusitis. Remember, this is bacterial, okay? And in almost 70% patients of sinusitis, the cause is bacterium, and these bacteria are like Streptococcus pneumoniae, Haemophilus influenzae, Moraxella catarrhalis. These three organisms, bacteria, they are common, whether it is sinusitis, whether it is otitis media. So remember that they are very common organisms affecting the upper respiratory tract also. These are the bacteria. However, one should remember that in children who come to you for rhinosinusitis, remembering that it is more likely to be bacterial, you are fully justified in using antibiotics like amoxicillin in the dose of 40 mg per kg per day in two divided doses, but for 10 to 14 days and not for 3 to 5 days. Because remember that these sinuses, or even for that matter otitis media, they are deep seated cavities, and it takes time for eradication of the bacteria from these deep seated cavities. Okay, let's see another case where there is a 6-year-old boy coming for fever and throat pain and vomiting, and there are swollen red tonsils with tender cervical nodes, which I told you earlier. They are indicative of acute tonsillopharyngitis. Okay, but remember that whenever you get a case like this, 70% cases of this pharyngotonsillitis are again viral. Only 30% are bacterial. Okay, and the bacterium which produces tonsillopharyngitis is known as group A beta hemolytic streptococcus. It is a bit different. Okay, however, remember that simple red throat does not mean that you should immediately start an antibiotic. This is very important, and that's why whenever it is viral infection, as I told you in the beginning, either the child will have conjunctivitis, coryza, cough, along with involvement of GI tract in the form of diarrhea, or the child might have hoarseness because of involvement of larynx, or he could have discrete ulcerative lesions on the tongue, or there could be rash. So all these indicate that there is viral infection. While Streptococcus pyogenes, the one which I told you, group A beta hemolytic streptococcus, will produce sudden onset of sore throat, and the age is 5 to 15 years. If you get a child under the age of 3 or under the age of 4 or 5, usually they are not the ones who are, the ones affected by Streptococcus pyogenes. So these are the children who will have fever, headache, nausea, vomiting, abdominal pain, tonsillopharyngeal inflammation, tonsillopharyngeal exudates, parietal petechiae, and anterior cervical rhinitis, and the nodes will be tender. There is, another manifestation of streptococcal throat infection which produces scarlet fever. This is, scarletiniform rash all over the body, and this is treated by amoxicillin. What you should remember is that viral and bacterial infections will produce different presentations, and your educated guess will guide you as to whether one should use antivirals or antibacterials. Some experts have, relied on a scoring system, and there have been some rules where one should be aware that temperature, absence of cough, tender anterior nodes, cervical nodes, and tonsillar swelling individually are given a mark. And the age group, as I told you, if the child is say around 3 to 14 years, then he gets additional 1 mark. Of course, if the age is beyond 45 years, then there is -1 mark. All this is called as a scoring system, just to help you to diagnose whether it is viral or bacterial. And depending on the score of that particular child, the percentage probability of Streptococcus pyogenes is decided. So if the score is 4, then there is almost 38 to 63% chance that the child has bacterial infection. Remember one important point, that absence of cough goes more in favor of bacterial infection. This is important. That's why that symptom has been given 1 mark. Again, in case if you suspect that it is bacterial tonsillopharyngitis, please use amoxicillin 40 mg per kg per day, and the duration should be 10 days. Okay. Now, what you should remember is that there are some tricky situations. For example, this child has, ulcerative lesions on the anterior aspect. You can see the lips are involved, the angle of the mouth is involved, and there is another child where there is an involvement of the posterior part of the palate. These ulcers are extremely painful. And remember, the first one is herpetic gingivostomatitis, and the second one is herpangina. So, herpangina is the enteroviral infection produced by Coxsackie A, and it involves the posterior part of the oral cavity. But remember, it is extremely painful, and the child is continuously crying, unable to eat. So the parents are worried. The child has drooling of the saliva, high fever in the beginning, and to the tune that, of course, irrational therapy will lead to the use of either amoxicillin or amoxiclav. The child remains the same, and by the end of 7 or 8 days, the child recovers on his own. Okay, so the treatment involves only symptomatic therapy in the form of relief of pain, maintaining the hydration, giving them, certain items which the child can tolerate, which are not very hot and spicy. So give them something which is cool. And of course, the child himself or herself will decide as to what, suits him or her. That is important. But then, it's really a testing time for the parents when they, get a child who suffers from herpangina. And you have to be really, really patient. Okay. And remember one important point, that in the routine pediatric practice, it is not necessary to test by nasopharyngeal swab, okay, to find out what is the type of the virus. However, whenever there is dilemma, for example, a child who is admitted in a hospital for lower respiratory infection, and you want to find out whether he has pneumonia because of influenza or some other virus, or whether it is bacterial pneumonia, then the nasopharyngeal swab will come for your rescue. One must remember that influenza has been classified into 3 varieties, A, B, and C. Actually, it's a classification for influenza-like illnesses, where type A means that the child has mild symptoms. He has cough, cold, and fever, but the fever is not very high. The child is otherwise hale and hearty. Saturation is normal. The child is not breathless. When the respiratory rate increases, or in a child who has higher respiratory rate, along with some high risk conditions. For example, the child who has congenital heart disease, or a child who has asthma, or a person who is on, say, steroids for nephrotic syndrome, or there is a mother who is pregnant, or there is someone who is really immunodeficient. So all these categories, they come under category B. These are called as high risk situations, where one should always remember that you have to rule out influenza as early as possible, so that here you are justified in sending the throat swab. And category C is the one where the child is a bit serious and the saturation is on the lower side, it's less than 92. The child could be breathless, and of course, this child might have cyanosis. He might be having, difficulty in breathing. His sensorium might be altered. So many things. He is not feeding well. So these are the children who might be the ones who are admitted to the hospital, and there you are fully justified in testing the nasopharyngeal swab for influenza and the other viruses, and at the same time you have to give them oseltamivir. Remember that pediatricians must be able to interpret the positive viral PCR results. What I want to say is that if you get influenza on the nasopharyngeal swab, you are almost 95% sure that it is definitely either H1N1 or H2N2 or H3N2, whatever is the type of the influenza virus. However, if you get some additional virus like rhinovirus, many times they are innocent bystanders. Okay, it's not that simple. However, one should remember that false positivity for H1N1, that is influenza, is not that common. And there are about 30% children where the nasopharyngeal swab may be negative in spite of the child having influenza. And that's because of, problems related to collection of the sample, because it requires a bit of a skill for collecting the sample from the nasopharyngeal swab for influenza. What I'm trying to say is that as far as possible, try to diagnose influenza clinically. If you are in dilemma, you are most welcome to send the nasopharyngeal swab for the diagnosis of the type of the virus. These days there are quite a few different panels also, which will only give you information whether it is influenza or RSV or some other virus. Okay, however, the secretions from the lower respiratory tract are, particularly used for the detection of bacterial infections, and our general pediatric population may not be, in need of such infections. They are mainly for the children who are indoor. So remember that there is a place of these PCR tests, and one should use them uh, appropriately. Okay, let us have a look at some other case. This is a case where there is a child who is 3-year-old and he visits the emergency room at 2 o'clock with history of sudden onset of breathing difficulty, preceded by history of mild cold and fever. And on examination, the child is restless but comforted by the parents, and the child has audible stridor, which is at rest, and it worsens when the child, and there is minimal intercostal retraction with a heart rate of 120 per minute, respiratory rate of 26, and saturation of 92%. Obviously, there is some problem in the upper respiratory tract where the voice box has been affected because there is stridor. What is stridor? That's an inspiratory sound, like the child is taking the air in at that time. Because of the narrowness of the larynx, the air finds it difficult to go inside. That's why it produces a sound. Okay, and because oxygen is going down, and depending on certain present the distress in this child, retraction, oxygen saturation, this particular condition, which is known as croup or laryngotracheobronchitis, there is a classification into mild, moderate, and severe. What one should know is that try to have a pulse oximeter with you, either in your pocket of the apron or on your table. Whenever a child comes with similar symptoms, check the oxygen saturation, okay? And you will be able to find out the severity of the problem. So this is the one where there is a triad, three things: barking cough, inspiratory stridor, and hoarseness of voice. I told you that hoarseness of voice is because there is involvement of larynx. Once the voice box is involved, the change of voice is bound to be there. Inspiratory stridor, because there is narrowing of the opening of the larynx, and that's why the air, when it goes inside, will produce a typical sound. And then there is barking cough, because It's viral laryngotracheobronchitis. So the trachea and the bronchi, which are bigger tubes, they are also involved, and that's why the sound when it comes out, when the air comes out by coughing, at that time the voice is also large, like a barking dog. So this is barking cough, inspiratory stridor, and hoarseness of voice, which is a typical triad of laryngotracheobronchitis. Okay, and the common virus which produces this problem is a parainfluenza virus. And as I told you, based on the stridor, restrictions, cyanosis, and heart rate, respiratory rate, mental status, it has been classified into three different categories. Of course, severe categories usually are treated under observations, and this child requires a position of comfort, observation for about 4 hours in the emergency room. Okay, and then they will also require steroids either in the oral form or nebulized form or intramuscular. Okay, and one may need to repeat the dose of nebulized steroids if the previous dose has been given beyond 12 hours. Okay, nebulized adrenaline is given if the symptoms worsen, and if the child is asymptomatic after 4 hours, then usually the child is discharged, but the parents are advised about the red flags. And one should remember that the steroids and adrenaline, they will help these children. And remember one important point, that children usually have a narrow airway. Okay, and that is why the resistance of the airway is supposed to be inversely proportional to the diameter. So as the diameter is small, the resistance is more. And that is why children present so quickly and so differently as compared to adults. Otherwise, in adults, we never discuss, this stridor and other things. There, the presentations are different. And children also develop all these problems very rapidly. So one has to be on the lookout. Even in the OPD, when the patients are sitting outside, if a child comes to you and if you just listen to him coughing like a barking cough with change of voice and inspiratory stridor, you can immediately instruct the nurse or the receptionist to get that child in fast. Okay, so it's always important. A child who is continuously crying is likely to be hypoxic. So my teacher used to tell me that whenever a child with gastroenteritis cries continuously, it is dehydration. No amount of sedatives is going to sedate the child. And a child who has cold and cough and fever, and if he is excessively crying, always remember that you have to rule out hypoxia. A hypoxic child will not settle unless you give him oxygen. Okay, so no amount of sedatives will sedate this child also. So it is important that you develop this particular observatory skill, hearing skill, visual skill, and that's very important. That is the most important thing in clinical medicine. Okay, otherwise sending an nasopharyngeal swab is a mechanical job. Taking an X-ray is a mechanical job. What is necessary at that moment is to detect that this child is serious or not serious. It's possible that some of you who are listening this program, have a very huge OPD of about 100 or 150 patients. Some of my colleagues have an OPD of about 400 to 500 patients in a day. So there is nothing wrong in having, so many patients, provided they are able to give enough time to each patient. But in that busy OPD also, the one who is able to differentiate a sick from a non-sick child is very important. So when you're in the OPD, try to differentiate a sick from a non-sick child. Try to decide whether a child requires hospitalization or no, child who requires investigations or no, and the child whether he requires some emergency management or no. Once you are able to answer these four questions, whether you see 10 patients or 100 patients or 500, doesn't matter, because you are not doing any injustice to the patient, because even in the busy OPD, you are able to differentiate. So this clinical knowledge is extremely important. Another child, 7-month baby, brought with complaints of increased respiratory movements and difficulty in feeding since one day, with a preceding history of runny nose and fever for a day or two. And clinically, the child has tachypnea, retractions, and wheezing. And this is bronchiolitis, which I just alluded to in the initial part of my talk, where it's, a pulmonary infection of the young children characterized by wheezing. It starts with cough and coryza, which leads to respiratory distress in 2 to 5 days. And there is fever and tachypnea. There is wheezing and prolonged respiration. Now, mind you, here I have not written anything about cough, because bronchiolitis is the infection of the lower respiratory tract. And whenever there is air in the upper the respiratory tract, there is cough because there are cough receptors in the airway. But the lower part of the respiratory system doesn't have cough receptors. So the child will not cough. But because of the problem with the gaseous exchange, the child will have, tachypnea. The child will have wheezing because these, parts of the respiratory system are, the ones where there is a bit of spasm, mucus plugging, and so on and so forth. And that's why some of these children have to be observed. Some of them can develop apnea. And as they are not in a good shape, they might develop dehydration. And if oxygenation fails or it is reduced, they may go into respiratory failure where there could be hypoxia and accumulation of carbon dioxide. And of course, the causative organism is usually respiratory syncytial virus in about 80% of the cases. And these children, they require only two things. One is oxygenation to maintain that the saturation is above 92%, and hydration. These two are most important. Unfortunately, some of these, children, they continue to get antibiotics and bronchodilators and corticosteroids for no reason. Remember, a child who is well hydrated and well oxygenated will recover because these are all viral respiratory infections, whether it is upper or lower. What they require is only supportive therapy. Obviously, it means that you have to rule out secondary bacterial infections also. So we have good, investigations at our hand, like the complete blood count, the CRP, and of course, as I told you earlier, we should be vigilant enough to observe this child. And the most important thing you observe is hypoxia. Okay, and after COVID, many of the parents also have these pulse oximeters in the house, and that's why many of these parents. Now recently I met a person from the IT sector. He was from the information technology sector. In fact, he came with the child and the pulse oximeter reading, and he said, sir, the saturation is 90. That's why I rushed the child over here. So you are lucky to have parents like these who themselves volunteer the diagnosis of hypoxia. Okay, so it's important that in your OPD you have an oxygen cylinder because many viral infections, they will complicate very fast into hypoxia, and it's important that you have the first aid. Okay, there are our colleagues who use hypertonic saline, nebulized adrenaline, but the role of some of these modalities of therapy are debatable. So my dear friends, you must remember that managing viral respiratory infections in children is a bit different than adults. The main thing is to rule out complications. So first, you triage. The word triage means classify whether it is mild, moderate, or severe. If you find it is severe, then just try to find out whether it is serious, whether I need to act urgently, whether I need to hospitalize, and whether this child is likely to be very, very, very serious. So whenever a child comes to you and you're not very sure, but your mind says that, oh, this is like to be influenza, there are so many cases going on outside, then you better start this child on Oseltamivir. Remember, Oseltamivir is a wonderful molecule and it's an antiviral agent. And in case if you know a bit about the microbiology of the influenza virus, it will be easier for you to understand, certain points about Oseltamivir. So this influenza virus is basically of three different groups like A, B, and C, of which type A is the one which is responsible for majority of the problems, along with to some extent type B. Now remember that the influenza virus has two important glycoproteins on the outer side. So on the outer side of this virus, by the way, is an RNA virus, and RNA viruses always change their structure. In fact, they change it every year. That is because the amino acid sequence of all these proteins, changes to a slight extent, and this is called as drift. Okay, that's why we have to give a different vaccine every year. Okay, every year the child receives influenza vaccine, and this composition of the vaccine differs every year. The point you should remember is that the H antigen is useful for this virus to get attached to the respiratory epithelium. So the virus has entered through the nose, it has gone down from the pharynx, and it is now trying to attach to the trachea and the bronchi. And there, the attachment is facilitated by this particular antigen H. Now, the virus has entered into the respiratory epithelial cell of the human beings. After entry, what happens is the another antigen, that is N, okay, N is the one which is responsible for helping the copies of these virions inside the respiratory epithelial cell to the other respiratory epithelial cells. And this exit of these viral particles or the virions is blocked by oseltamivir. And that is why oseltamivir is called neuraminidase inhibitor. H is hemagglutinin, N is neuraminidase. Both are glycoproteins. H is responsible for attachment, and N is the one which is responsible for the exit of the virus from the respiratory epithelium to the other respiratory epithelial cells. So once the exit is blocked by this neuraminidase inhibitor called oseltamivir, the progression of the disease is halted. So whether you give it in the initial 48 hours or if you give it after 5 or 6 days, it matters, but doesn't matter to a great extent, because you have to give this whenever the child is brought to you with a diagnosis of influenza or suspected diagnosis of influenza. It is the best to give it under the period of 48 hours. That is because you will be halting the progression fast, okay? But doesn't mean that you cannot give it when the child comes after 5 or 6 days, because the replication continues. And that is why during this pandemic of influenza, in some of the institutes where I keep working, when we used it even for children, after 5 or 6 or 7 days, when the children used to get admitted with influenza, it reduced the rate of hospitalization and mortality. So if someone asks you as to how oseltamivir helps, number one, give it within 48 hours so that the progression of the disease is halted, severity is reduced, hospitalization is reduced, and the mortality is reduced. So it's a wonderful antiviral agent, and there are very few antiviral agents which are used in the management of viral respiratory infections. So early therapy, that is number one. Number two, diagnose hypoxia on time, maintain the hydration, and give symptomatic therapy. Of course, with the help of investigation, you can find out whether there is a secondary bacterial infection. Remember, in influenza, in 25% cases, that is almost one-fourth of the cases, there is additional bacterial infection with staphylococci or pneumococci. And that is why, particularly in children with influenza, remember that you have to be on lookout for secondary bacterial infections also. Okay, this is important. And that's why not only the influenza vaccine, but even a child who has received pneumococcal vaccine, will have lesser problems, because these children, will not get influenza because they have received influenza vaccine. Even if they get influenza in spite of vaccination, they will not get secondary bacterial infection because they have received pneumococcal vaccine. So all in all, the problems in this child will be lesser. Okay, and it's very important that once you are aware of all these details that I have been trying to tell you, you can reduce the inappropriate antibiotic use. You can tell the parents that, see, these are viral respiratory infections and they are known to occur 8 to 10 times in a year. So these are back-to-back viral infections. Your child is going to the daycare center. Other children are donating him these infections, but these are all viral. Don't worry. The child is gaining weight. The child's growth chart is normal. So you treat this particular child and treat this cold and cough. And remember that cold and cough are additional members of the family. They are growing with your child. The child will grow with them. Provided the growth chart is normal, you need not worry, and do not give antibiotics each and every time the child is unwell. There are many parents, as I told you, from the IT sector. I many times jokingly say that the IT sector, IT stands for inquisitive and troublesome, because many times, they, ask many questions. Sometimes it's quite a pleasure to answer to their queries, but sometimes it really becomes troublesome, particularly at the end of the day when you're really tired. But that's a part of your job. And that's why, many of them, they want me to tell them whether this child requires antibiotics, whether he can go to the school tomorrow. The exam is tomorrow, sir, why don't you give antibiotics? Sir, will you do this? Will you do that? So you have to be ready with all these answers. And I hope that, our program of this nature helps you answering them. And it's important because, they are, well-educated parents and they are well-read. They refer to the Google. But what you have in addition to this information from Google is your experience, your priority, as to when to use this, when to use that. That is something, which is, something which the AI or the Google cannot tell. That is the importance of the clinical examination and your experience. Okay. So remember that influenza, as I told you in the beginning, it differs from other viral respiratory infections. In fact, it is the father of all the influenza-like illnesses because it produces symptoms which are distinct, like high fever onset with chills, headache. The child might have weakness in the legs and severe pain. None of the other viral infections produces such a presentation. So you have to be on alert. So, a child coming for cold and cough, make it a point to ask this specifically. An older child lifted by the parents, 8 or 10-year-old child brought by the father on the shoulders, many times turns out to be influenza. Okay, you have to know all this. Okay, and as I told you, there are certain children who are under the age of 5 years, those who have some underlying heart problem or the respiratory problem, kidney problem, some immunodeficient state, malnourished children, they are at a risk of getting severe influenza. Even, the fact that influenza mainly attacks children has to be remembered because COVID usually attacks older people and then that will affect the younger ones. Influenza is the one which attacks the younger children first, and younger children will donate virus to the other members in the family. So it is your duty to ask whether there is someone in the family who is, having asthma, or whether mother of this particular child or some other relative is pregnant, whether there is a father who is diabetic, grandfather who is asthmatic, whether someone is receiving steroids. Once you know that, in addition to giving oseltamivir to this child, you will be able to give medication as prophylaxis to the other household members. Remember that treatment with oseltamivir is usually given for 5 days, and the dose of oseltamivir is in the form of twice daily dose. Adults receive 75 milligrams twice daily, while children will receive it in the dose of milligram per kg, and depending on the weight bands, the dose either of the syrup or the capsule is decided. Remember that chemoprophylaxis is given in a single daily dose, but it is given for 10 days. Okay. And remember that the antiviral treatment for influenza should be initiated as fast as possible within 48 hours empirically. Even WHO has supported empirical use because everyone is aware that earlier you use oseltamivir, results are better. Okay. And of course, in addition to some of the strategies that I told you, there are some preventive strategies like the ones which are related to the use of the hand. For example, after checking a child or a patient, you have to wash the hands because usually your hands will carry the viruses. You have to use a handkerchief. You have to cough in the elbow. You have to see that you avoid handshake, and you have to see that the other person is kept at a hand's distance. So I call this as Hasta Pancha Sutri. These are the 5 sutras related to hand in case of preventing the viral respiratory infections. It is very important. So my dear friends, remember that viral respiratory infections are the bread and butter in your practice, and do not take them casually. Just do not give antipyretics and antihistaminics and then dispose of the patients, but go into a bit of a depth. Okay, ask further details about the history, rule out whether it is influenza, check for oxygenation, maintain the hydration, use oseltamivir fast. If you find that it is likely to be bacterial, no doubt you can use amoxicillin. If you are in two minds whether this is viral or bacterial, use the score that I told you. If a child is unwell and the respiratory rate is high, you may think whether the child needs to be admitted. But in an admitted child, you must check the nasopharyngeal swab for influenza. You must give oseltamivir for all the admitted children with pneumonia. Okay, and these are some important points that you must remember. And most important is that protect yourself by wearing a mask, because children many times they cough directly on our faces and we don't have anything to protect ourselves. So please use a mask, and at the same time protect yourself by taking influenza vaccine. Every year the vaccine changes because the strain of the virus circulating in the atmosphere changes. I told you that there is something called as a drift means the minor changes will make the structure of the influenza virus different, and there is a shift which occurs in pandemics. So 1919, 1957, 1968, and 2009, there have been 4 major pandemics up till now where there was a major shift. That means totally new influenza virus came into the atmosphere, against which we did not have any immunity, and that's why the morbidity and the mortality was quite high at all those, four pandemics. So protect yourself by taking influenza vaccine every year. So I always tell my parents and children who come to me that happy birthday to you, followed by happy birthday to flu. That means flu vaccine to be taken every birthday. Okay, so every birthday, make it a point. In addition to cutting the cake, you please see that you get yourselves protected against flu. And also, I have made it a practice to give flu vaccine to all the staff members in my hospital, the receptionists, the IRs, the ward boys, and the resident doctors, because they are the ones who are also exposed to these viruses along with you. And in fact, it's our responsibility to see that all our family members are also protected, because as pediatricians, when I come back home, or when you come back home, our family members are exposed to all the viruses which we carry home. So it is better that you protect all your family members also. So there are many key messages in this particular talk, and I am sure our learned colleagues will take up the important points from this particular talk. I thank you for a patient hearing, and hand over the proceedings to Dr. Prashant. Thank you.
Sir, thank you very much. Those key messages are really important. And as you rightly said, we have to protect not only ourselves but our staff also, to help prevention, I mean, to help spread of virus and getting infected. Thanks so much. Thanks all the doctors who took time and attended these sessions. Thanks, Dr. Zog, once again. It was a lovely session. Thank you so much. Thanks, Sanjana, and thanks all the sales force for coordinating. Thank you, sir. So wish you a very good afternoon. You can log out, sir. Thanks, Sanjana.